palliative care. Okay, so as was discussed earlier, okay, this part 3 consists of 8 major topics, and the 3 speakers will divide these topics. Okay, so I'm tasked to give you these first 3 as outlined here in my slides. Okay, I'll provide you with the background. Okay, and why and who should use these guidance documents, the general principles and the responsibilities of our healthcare providers, and the healthcare challenges in the COVID-19 response scenario. Okay, so first of all, why did we develop this guidance? Okay, the part 3, why was it developed? Okay, first of all, because of the need for a realistic and uniform process of communication. It will all boil down to communication in the context of this present COVID-19 situation, okay, and its effect on the human and medical resources, okay? So I'm talking in particular about setting of goals of care, okay? This would also include processes of shared decision-making and processes of triage, okay, for the intensive care treatment. Okay, so a greater part of which has been adopted from existing international guidelines on the ethical framework for decision making, because it's important to have a decision guide for advanced care directives, and also when do we need palliative care, specifically in this COVID situation. Okay, so who should use this guidance? Okay, so sino po ba sa atin? Okay, so of course, healthcare professionals, including doctors, nurses, and hospital management from level 2 and level 3 hospitals with COVID-19 patients or other patients facing life-threatening illnesses. Okay. Okay, so, and then knowing about who to use, who would benefit this and why was it created, we need to consider what ethical principles are involved. Okay, so marami yan, but there are 6 cited with this triage decision-making or shared decision-making. Okay, first of all, we're talking about equity. So when we talk about equity, available resources are to be allocated without discrimination. Okay, so the decision should be made in such a way that we have to ensure that a few people or possible become ill during or they die. Okay, so the allocation of such resources or the procedures must be fair, objectively justified, and most importantly, transparent. Okay, next. Okay, so what ethical principle is? We're talking about preserving as many lives as possible, okay, under the conditions of acute scarcity, and all measures are guided to be aimed of minimizing the number of deaths. Okay, third, okay, protection of the professionals involved. Okay, so utmost protection for professionals, including have to address the physical and psychological stress that it involves here. Okay, so fourth ethical principle, okay, is the right to information on health status. Okay, this is very important and sensitive because the patients really have the right to determine, and they also have the right to refuse the information. Okay, we know that every human being, okay, will have different histories, okay, and we all have different sets and or collections of fears, concerns, and values. So when we consider providing information, it has to be tailored to the needs of the patient and taking into consideration the values, okay, yung religious, ethnic, linguistic specificity of the patient and the family. Okay, so fourth ethical principle that this guide that is used here is the right to informed consent. Okay, so the right to access all information that might enable him or her to actively participate in the decisions regarding health. Okay, so healthcare providers, okay, are to provide information relative to treatment, including the risks involved, okay, the discomforts, the side effects, and possible alternatives. So that's about informed consent. Okay, so what about patient autonomy, or we're talking about self-determination? Okay, so the requirement, what I discussed earlier about patient's consent, okay, or for the consent of the individuals, okay, for treatment protects actually three ethical principles. Okay, so from harm, which is your non-maleficence, benefits, this is doing good, beneficence, and respect for autonomy or self-determination. Okay, so providing the information about advantages and disadvantages of any, okay, proposed treatment enables the patient to reflect and deliberate on whether or not to refuse the treatment that is offered. The key here is actually a regular communication with the family and the patient to review goals of care and advanced care plan. So I've discussed the 6 important fundamental ethical principles that is applied in this, that were applied in this guidance document. Now let's go to what are the healthcare challenges in the COVID-19 response scenario. There are 3 unique healthcare challenges. Okay, so first is the duty to plan, okay, the duty to safeguard, and the duty to guide. Okay, so what about the duty to plan? The key here is uncertainty. Okay, so healthcare leaders have a duty to plan for the management of foreseeable ethical challenges during a public health emergency. So ethical challenges arise when there is uncertainty about how to do the right thing in clinical practice when duties and values conflict. Okay, so this planning for these foreseeable ethical challenges include sometimes identification of potential triage decisions, including the tools and the processes. Okay, and these triage decisions might come into decisions about level of care. Are we doing ICU, medical ward? What about initiation or withdrawing life-sustaining treatment? These are sensitive issues. Even referral to palliative or comfort-focused care, and concerns specifically of shortages of staff, space, and supplies. Okay. Next is the duty to safeguard. Okay, supporting workers and protecting the vulnerable population. Okay, so the facility have the duty to respond to public health emergencies by safeguarding their healthcare workforce. Okay, specifically in this COVID scenario situation that well predicts deteriorating environmental conditions and heightened risk of occupational harms. Okay, lastly is the duty to guide. Okay, this is interesting. Okay, we're talking about contingency levels of care and crisis standards of care. Okay, so a severe respiratory illness such as COVID-19, okay, will be requiring the need for ventilator support for patients who are in the ICU. Okay, so this would entail monitoring of trained staff, your intensivists, your ICU nurses, including respiratory therapists. Okay, so everybody will be focused on that. Okay, but ICU beds and staffing are already, or hope sana hindi naman, becoming scarce resources, specifically during a surge of critical ill patients. So sometimes mafi-fill up na talaga ang available beds natin. So it will all boil down to the shortage of staff, space, and supplies. So ideally, what we do is first come, first serve basis. Okay, but in this kind of situation, okay, the approach for allocating critical resources can be varied. Okay, so sometimes these critically ill patients waiting for an ICU bed, okay, might be of benefit for, if from this resource, if for a, compare if there is already a patient in the ICU but is not improving. So how do we go about it? Okay, so that's why a hospital or health system's institutional ethics services is warranted. Okay, bioethics consultation. Okay, they should function as resources for clinicians experiencing uncertainty and distress under under these abnormal conditions. Okay, so I think that's the end of my part. I will now go give the floor to Dr. Rojim Sorosa, who will discuss the next part or the content of the part 3 guidance. Thank you.
Okay, thank you very much, Dr. Estepa. So if you assist me, you'll be in charge of the slide projection. So there you go. So good afternoon, everyone. And my topic will be about triage decisions, shared decision making, and we'll discuss algorithms involving shared decision making, conversation guide, patient, family, physician communication. And I'd like to share also the pathway that we made in order to provide family care and psychosocial support to all our critically ill, suspect, probable, and confirmed COVID patients who are admitted in the intensive care units. Next slide, please. So what about triage decisions? So as a general advice for triage decisions, these are patients requiring intensive care that are to be admitted and treated within established criteria. So for COVID facility centers, at this point in time, I'm sure they already have their own criteria for those patients who will be admitted in the ICU. So triaging, it's a process of determining the priority of patients' treatments by looking at the severity of their condition or likelihood of recovery with or without the treatment. This triaging is also a process of which requires preparation of a triage system to best allocate resources, critical care resources, in order to meet a severe surge to maximize benefit for the greatest number of people. So triage policy implemented by clinicians trained in triage or senior practitioners, and they're complemented by clinical decision support systems. And they aim to identify patients with such a low probability of survival and that they are unlikely to benefit from ICU care. So part of this triaging process is to identify those kind of patients too. And so I have come across with an article written by Mabes et al. About the different operational steps to implement a triaging system within the ICU. So there must be inventory of potential ICU resources for a surge in demand, establishment of identification triggers for initiation and triage. For instance, if you have an elderly patient with several comorbids, elderly patient with multiple medications, patients who are severely disabled, and these are trigger points to which you might be able to initiate more critical conversations, such as the need for advanced care planning, the need to tackle issues about directives, the need to tackle issues about aggressiveness of medical care. So all these things are important triggers, especially if you know the data in your institution and the kind of patients you are treating and are managing. So, and then this also entails preparation of a triage system, which should be there should be interdisciplinary collaboration, and in doing so, there should be agreement on a triage protocol to target resources to those with the greatest incremental benefit, and consideration of changes to allow limits to the delivery of life-sustaining measures in times of crisis, and indemnify against litigation for decisions made in accordance with triage policies, and incorporation on the standards of medical care. So that means looking at the PISME guidelines, our local guidelines, in order to look at management that can actually benefit our patients admitted in our own treatment facilities. Also, family care and societal support, healthcare worker support, and also we have some pediatric considerations. So next slide, please. So the role of the triage committee is to apply the criteria for ICUK, an assessment of mortality risks using sequential organ failure assessment score, your SOFA scores, which determines the probability and likelihood of morbidity and even mortality for those patients who have a tendency to go into sepsis and then eventually to septic shock. And then also, of course, to revisit all these decisions over time, especially for ventilated patients, and to come up with collaborative decisions to include patient and or family in these decisions, so that you can revisit these decisions and change your goals of care as the need arises. And so therefore, there is a need not only to communicate within the interdisciplinary team and all the other extended team members, but also there is a need to communicate this to the family. So next slide, please. So, and this is the importance of which is for us to be able to incorporate what we call shared decision making. So shared decision making, as defined in this guidance document, is a key component of patient-centered healthcare. It is a process in which clinicians, patients, and families work together to make decisions and select tests or treatments and care plans based on clinical evidence that balances risks and expected outcomes with patient preferences and values. And we have done this with our patients admitted in the ICU, granting that all these patients are in the stage of major therapeutic efforts. And sometimes there might be questions where families begin to look at whether or not these aggressive treatments will benefit their patient or not. And we make advices and at the same time try to collaborate with the attending service and see whether or not it is the right time to talk about prognosis or otherwise. Next slide, please. So what are the key concepts of shared decision making? So this entails, of course, good communication. And sometimes when we are not trained to communicate, or when we have difficulties in communicating to our patients and to our colleagues, this could lead to conflicting goals of care, especially if the patient is being cared for by multiple services, a lot of members of the team, and notwithstanding also the family that they're into. And sometimes these families have extended family members, etc. Patient autonomy as much as possible should also be preserved. So in all these particular circumstances, just like our experience with dying patients, with patients who are critically ill, as much as possible, we give them that sense of control. And they should be able to actively participate in the decision-making process. And this gives them a sense of empowerment. Decision-making should always be patient and family-centered. Next slide, please. So the recommendations of this guidance document includes the active training and education to healthcare workers. There is a need for interprofessional collaboration and increase the capacity to decision making, to invite the family members and to be able to give support not only to the patient but to the rest of the family members as well. And also, we need to check if everyone is on the same page, because if they are not on the same page, then otherwise this is something that's going to create problems in the future. So the tools to evaluate if the patient correctly understands the information. So we have specific tools for that. For instance, we have the CEA approach in order to correct any emotionally critical misperceptions or misconceptions about the care for these patients. So shared decision making is also used for advanced care planning. So as long as there is a common framework, then we can make the goals of care as a whole and collaborate effectively with the rest of our colleagues and to the family members. Next slide, please. So here is the Annex B, which is a shared decision-making conversation guide. So this conversation guide allows us to have a common framework that we can work upon so that our conversations to the patients that we are taking care and to the family members, immediate family members, are the same. So we invite them to participate in the discussions. We present different options of care. It is very much like the informed consent process, where you present the benefits of the intervention, the risks of the intervention, the likelihood of progression if these standards of care are not followed, and at the same time, alternative courses of action. So therefore, in using this approach, we are able to balance whether or not the risk outweighs the benefit or the benefit outweighs the risk. So in this process, we assist patients in evaluating options based on their goals. So we have to be prepared if, for example, patients would really want aggressive and maximal care. I will show you. I will share to you later on the data that we have when we collected, when we recorded all the referred cases in our treatment facility, because in this particular scenarios, a lot of these patients are in the stage of major therapeutic efforts, rather, as compared to patients who are suffering from stage 4 cancer or end-stage disease. This is something that's sometimes acute and very sudden. And then to facilitate deliberation and decision-making process and assist patients to follow through on that decision, and then revisit again, monitor and evaluate the responses and the effects of that decision, and try as new information is gathered. Next slide, please. In Annex C, which is entitled Patient and Family Physician Communication Guide, it's very important that the family and the patient should feel that the support coming from each and every one. And this, I have been very, very consistent in telling all the residents, the consultants, so that the patient does not feel abandoned, especially when you say that the prognosis is very, very poor. So ensuring comfort by communicating to the patients from beginning, during, at the end is very, very essential. So you ensure comfort by addressing the person, using the person's name. Do not call them the case. Do not call them the case or patient number 2655, something like that. So address their names as much as possible. You also need to assess emotional temperature. You don't know, you might be opening a Pandora's box. So it's very important to ask questions. How are you feeling today? How have you been feeling in the last 24 hours? Are you comfortable? And then when you begin to ask these open-ended questions, you have to actively listen. So this means that you need to use your active listening skills. And active listening skills requires you to listen with compassion. And in this kind of scenarios, when you try to listen to your patient, sometimes we have major roadblocks that may entail the following: judging the person, criticizing them, or name calling because they're not able to follow your suggestions. you suggest solutions so that you can actually simplify your communication by means of ordering or excessive inappropriate questioning. And then sometimes we avoid the conversations or the person's concerns and we divert them to other topics. So these are roadblocks that we need to address
Sa
as
labas,
soon as
yung
we
drinks,
listen to our patient's concern.
yung in-order niya food
The other
panda,
one is we need to
isang
reassure.
pinapakuha, is daw kami.
Okay, so there's a noise interference, so maybe request the other mics. Especially if you have new things in the medical management, new things in the patient's clinical condition. Always ask the question, so what do you understand now? What have been explained to you by the doctor, by the nurse, by the rest of the team caring for you? And deliver information with empathy. So this means you need to avoid technical terms and use very simple terminologies. If you're delivering a bad news, give warning shots. I am afraid that I have bad news to say to you today, and this entails about, and this is something to do about your medical condition. So things like that. And to use your senses to look at verbal and nonverbal cues. A patient might actually say they are okay, but when you try to look at their facial expressions, they're not okay. So then we have to use statements to support their emotions, their feelings, and to provide support as well. Next slide, please. So in my last slide, in the second to the last slide, this is a decision algorithm that we propose to the infectious disease experts and all the rest of the core team about how to provide family care and psychosocial support for the critically ill patients who are suspects, probable, or those with confirmed positive case, patients. Next slide, please. So this algorithm is about accessing family care and psychosocial support. So if they it does not follow that when you cannot see them face to face, or you cannot touch them or visit them personally, it does not mean that you cannot provide support. I would like to emphasize on that, because everything here that we did was to communicate to our patients using the best of technology, using mobile phones. We use a messenger, etc., only to provide emotional and family care support. So, but before doing that, we try to elicit as much information as we can in order to understand the overall clinical condition of the patient. And once you're able to do that, we begin to initiate family and psychosocial assessment using family assessment tools, using communication tools, etc. And once we are able to determine the needs and the goals of care, we continue to provide the care, support them the best way we can, and revisit and change the goals of care if there is new information. And if this is meeting the family's needs, then we continue to provide until they're able to go home or be discharged from the ICU or be discharged to a step-down facility. And we provide more, especially if, for example, we know that this patient is deteriorating, and so therefore we use other hospice care related strategies to initiate end of life care discussions. Just to give you examples of what we've experienced in the majority of our patients whom we've handled in Southern Philippines Medical Center, those who were referred to palliative care and family medicine for support. Majority of these patients are in the stage of major therapeutic efforts. And then, well, since these are all critically ill, so we only got to contact them in a small fraction of the cases that were referred to us, but almost 100% we were able to establish and contact the family members. And by the time they're able to reach the ICU, almost 70% of these patients do have advanced healthcare directives. And we are very glad because sometimes the residents, when they were trained or they received continuing medical education for palliative care, they're able to initiate such critical conversations. And so majority of these patients have advanced healthcare directives. And majority, since these are acute, sudden conditions, potentially irreversible, but maybe life-threatening on one end, majority of these family members and patients have expressed a full code status plus supportive management. And in these patients, majority of the patients that we were able to talk to reported distressing physical symptoms. That's almost 80%. So majority of our palliative care interventions were mostly physical interventions. There's one patient of ours who was initially admitted to ICU, but was discharged from the ICU and then eventually in the step-down facility, and she was very anxious. She was very anxious. She had palpitations, although she was diabetic, non-hypertensive, and she was very anxious and she couldn't sleep at night. And so if we were not able to pick this up, her quality of life could be severely impaired, even though she's in good hands already. But the experience of distressing physical symptoms can be very, very problematic in terms of affecting the quality of life. So this patient received benzodiazepines, and she had very good and positive responses. And as a matter of fact, she's doing very well right now. So we were also able to elicit families' predominating concerns. And majority of these concerns, in contrary to patients' concern, which is mostly physical in nature, majority of the families expressed emotional, psychological issues and practical needs. I'd like to share with you, there's this two patients of ours we've cared for, and this patient had a very simple request inside the ICU. She was a CKD5 patient undergoing regular hemodialysis, but because she was physically weak and she said to us she was dependent on her husband, a simple request was made to open the mineral water and to open the food that was prepared to her, because she had no strength to do all these things. So if these would not have been picked up, it could severely impair her quality of life while staying inside the ICU. So we had to call the nurse in charge, talk to the resident on duty to attend to the practical needs of this patient. And then eventually when this patient died, the family was at a loss as to what to do next. So we had to do a lot of collaboration. So it's mostly social work services to guide the family members where to put the body next, how to coordinate with the funeral services. We've done this also to our pediatric patients, since 50% of our census were also coming from the Department of Pediatrics. So issues like this, as my ending statement, are very important to us because, for one thing, these are not normal, the normal things they experience, because staying in the ICU without the family members at your bedside can really trigger a lot of existential issues. And if there's one thing that's most feared about by a lot of persons, even if you ask yourself now, what's the worst thing that could happen to you when you face your own death? It's actually dying alone. And so when conditions like this progress and there's no point of no return, then we should do all in our knowledge, in our capacity, in our skills to make the person's experience as favorable, as dignified, and as peaceful as possible. And that is the essence of providing palliative and hospice care to patients afflicted with this virus. So that ends my talk. Thank you very much.